Welcome back to the deep dive. Today we're taking a closer look at, well, something really common, painful menstrual cramps, or what the medical world calls dysmenorrhea.
Yes, and for this deep dive, our source material is quite specific. We're working from a set of high-yield MSRA revision notes focused just on this condition.
Exactly. So our aim is to take this pretty dense material and really unpack it for you. Pull out the most important need-to-know bits.
Making it easier to digest, think of it as us guiding you through those revision notes, making sure the core concepts stick without getting bogged down.
We'll cover what these notes highlight, from what dysmenorrhea actually is, why it happens, right through to diagnosis, management, and the long-term picture.
It's about getting that essential understanding. The notes break it down really well, the different types, the mechanisms, how it presents, and crucially, the practical steps for assessment and managing it. You get into the why and the how-to.
Okay, then, let's unpack this. It's something incredibly common, affecting so many people. And really understanding the details from this material, well, it can make a huge difference whether you're revising or actually in a clinical setting.
Absolutely. And what's helpful is how the notes provide such a clear structure, starting right at the beginning, logically, with the definition.
Which is pretty straightforwardly painful menstrual cramps that happen during menstruation. And the notes describe the pain as typically in the lower abdomen or pelvis, often cramp-like.
Yeah, cramp-like. And it can radiate, sometimes to the lower back, even the thighs.
Right. And straight away, the notes bring in this really fundamental concept, the classification, primary versus secondary dysmenorrhea.
And this distinction is absolutely critical. It underpins everything else, really diagnosis, management, the lot.
Got it. So based on this material, primary dysmenorrhea, that's when there's no underlying pelvic condition causing the pain.
Exactly. No other pathology going on. And it's incredibly common, the notes suggest, maybe up to half of all menstruating individuals experience it.
Wow. And the timing they mention. It typically starts just before or during the period itself.
That's the classic timing for primary. The notes hint the cause is linked to prostaglandins, which we'll get into.
Okay. And then secondary dysmenorrhea.
That is caused by some identifiable underlying issue in the pelvis. Something else is going on.
And the notes list specific conditions to think about.
They do. Things like endometriosis, adenomyosis, PID, that's pelvic inflammatory disease. Also issues with intrauterine devices and fibroids.
And a key difference here, highlighted in the notes, is the timing again.
Yes, the timing can be a big clue. Secondary dysmenorrhea often starts earlier than the primary type. Sometimes, 3 or 4 days before the period actually begins.
Ah, okay. So the first big takeaway from these notes seems to be nailing that distinction. Primary. Pain without another cause, starting right around the period. Secondary, pain because of something else, potentially starting a bit earlier.
Exactly. And that timing difference, that's a really high yield point for revision. Definitely one to remember.
It immediately makes you think, doesn't it? Are we just treating the pain, or is there something deeper we need to look into?
Precisely. And the notes are clear. If you suspect secondary dysmenorrhea, referral for further investigation is recommended. You need to figure out that underlying cause.
Makes total sense.
Okay.
So let's dig into the why a bit more. Why does the pain actually happen, especially for that really common primary type? The notes go into etiology and pathophysiology.
Right. So what's highlighted in this material for primary dysmenorrhea is that it's driven by a specific biological process. It involves the release of chemical messengers called prostaglandins.
Prostaglandins, okay.
They're released from the endometrium, that's the lining of the uterus during menstruation.
And what do these prostaglandins actually do? The notes link them directly to uterine contractions and pain.
That's the core mechanism. The pathophysiology section explains that dysmenorrhea seems linked to an excess of these prostaglandins and maybe other inflammatory things like leukotrienes in the menstrual fluid.
An excess of them, okay.
And these substances cause vasoconstriction,
Meaning?
tightening or narrowing of the blood vessels within the uterine wall.
Ah, okay. So, constricted blood vessels plus strong uterine contractions. That sounds like it would definitely cause pain.
It does. That combination reduces blood flow to the uterine muscle tissue while it's cramping hard. That's what causes the characteristic pain.
And what's interesting, you mentioned earlier the notes link these prostaglandins to other symptoms too, not just the cramps.
Exactly. Here's where it gets, well, even more interesting. It's not just localized pain. These prostaglandins can have effects beyond the uterus.
So that explains why someone might also feel nauseous or have diarrhea.
Precisely. The notes explicitly mention that these prostaglandins may also cause symptoms like diarrhea, nausea, headache, even feeling lightheaded. It's like a systemic effect from those same chemical signals.
Got it. So the prostaglandins explain the cramping and potentially feeling sick or having gut issues. That's a really useful connection from the notes.
It is. And just briefly, for secondary dysmenorrhea, the mechanism is different, obviously. It's the underlying condition itself causing the pain. So inflammation from endometriosis, pressure from fibroids, infection in PID, that kind of thing.
Right, the pain comes from the specific problem. Okay, let's shift gears slightly. Who does this typically affect, and how common is it, according to the source material? Epidemiology and risk factors.
Well, the notes indicate it's incredibly common, particularly looking at the UK. They say up to 80% of women experience some degree of dysmenorrhea.
80%, wow, that's a huge number.
It really is. Severe pain, though, affects a smaller but still significant group, maybe around 5 to 10%.
So it's something most people who menstruate will likely encounter at some point.
Almost certainly. It's most prevalent during the reproductive years. The notes give figures as high as 40 to 90% in that age group.
And do the notes list specific risk factors, things that might make someone more likely to experience it or maybe experience it more severely?
Yes, they do list a few key risk factors to be aware of.
Such as?
Starting your periods at an early age, that's early menarche. A family history is also noted.
Okay.
Also having heavy or prolonged menstrual periods. And then lifestyle factors. Smoking and obesity are also included in the list from the notes.
Okay, so that's a useful checklist from the notes. Early start to periods, family history, heavy flow, smoking, obesity. These might increase the risk.
Those are the main ones highlighted. And there's a small positive mention, too. The notes say it often tends to improve as people get older.
A small silver lining. Right. Okay, moving on to clinical features. What does this actually feel like for someone experiencing it, according to the notes?
Well, they reiterate the core symptom we've already touched on, that cramp-like lower abdominal pain.
Which can radiate to the back and thighs.
Exactly. And the timing is key, again, especially for thinking about primary versus secondary. The notes specify the pain typically starts just before or during menstruation.
And lasts how long?
Usually for several days. They give a specific range, actually. 12 to 72 hours. That duration is a useful detail to remember for revision.
12 to 72 hours. Got it. And the age it usually starts, does it mention that again?
Yes, it reinforces that it commonly begins during adolescence, usually within, say, 4 or 5 years of the first period.
Okay. And those other associated symptoms, the ones we linked potentially to the prostaglandins?
Yes, the notes list them again under clinical features, really hammering home the association. Things like nausea, vomiting, diarrhea, or maybe constipation, headaches, or dizziness.
Fatigue, mood changes.
Those two. Fatigue, mood changes, and just a general sense of feeling unwell or malaise. The material paints a clear picture. It's often not just the pain, but a whole constellation of symptoms.
Right. So if someone presents with this picture, how does a clinician figure out exactly what's going on? This takes us to differential diagnosis. What else could be causing this pain, particularly if secondary dysmenorrhea is suspected?
This section is so important because, like we said, managing secondary means treating the underlying cause. So the notes provide a crucial list of conditions that need to be considered, thought about, and potentially ruled out.
And the key culprits highlighted in this material are...
Endometriosis is a big one. That's where tissue similar to the uterine lining grows outside the uterus. It causes inflammation, adhesions, can be very painful.
Okay, what else?
Uterine fibroids, those are non-cancerous growths in the uterus that can cause pelvic pain and heavy bleeding, pelvic inflammatory disease, PID, that's an infection, usually sexually transmitted.
Right.
Then there's adenomyosis, where the lining tissue actually grows into the muscular wall of the uterus itself. Causes pain, often heavy periods too.
Adenomyosis, got it.
And finally, ovarian cysts are mentioned. Those fluid-filled sacs on the ovaries can cause discomfort, or sometimes sharp pain if they rupture or twist.
So if the symptoms, maybe the timing, suggest secondary pain, these notes give you a really clear checklist of potential underlying issues to consider.
Exactly. This list is vital because the management approach really depends on finding out if one of these is the cause, and if so, which one.
Which leads us perfectly into investigations. How do doctors actually look for these conditions or confirm a diagnosis?
Well, the notes emphasize, starting with the fundamentals, a really thorough medical history and a physical examination.
The basics first.
Absolutely. They even make a practical point. For young patients who aren't sexually active, you might make a presumptive diagnosis of primary dysmenorrhea just based on their history, and maybe an abdominal exam.
Sometimes the story is enough initially. What specific things does this material say are important to ask about in the history?
Quite a detailed list here. Age when periods started, cycle length, regularity, how long the bleeding lasts, the timing and location of the pain, remembering that primary versus secondary pattern, smoking history, sexual activity, any past pregnancies or contraceptive use. And critically, asking about any features that might suggest an underlying problem, like pain outside of the period, pain during sex, or really heavy bleeding. Red flag type symptoms.
Okay. And the physical examination. The notes mention abdominal and, if appropriate, vaginal exams. Are there specific findings highlighted as important clues in this material?
Yes, and this is where the notes give some really high-yield physical signs to look for, particularly if you suspect adenomyosis or endometriosis.
Okay, what are they?
For adenomyosis, the material notes the uterus might feel enlarged and tender when examined. For endometriosis, clues might include general pelvic tenderness, maybe finding the uterus is tilted backward and feels kind of stuck. They call it a fixed retroverted uteruses.
Right.
Or sometimes you can feel small, tender bumps or nodules in the ligaments behind the uterosacral ligaments. Finding those palpable nodules is a classic sign mentioned.
Those specific exam findings, enlarged tender uterus for adeno, fixed retroversion or nodules for endo, those are definitely key memory hooks from these notes.
Absolutely. Beyond the history and exam, what investigations are listed?
The notes mention pelvic ultrasound as a key next step, often done transvaginally, to look for any underlying uterine or ovarian issues, fibroids, cysts, sometimes signs of adenomyosis.
Okay, imaging first.
Yes. And also swabs for infection. High vaginal swabs, chlamydial swabs to rule out PID. Simple tests, too, like a urine pregnancy test, obviously crucial, and urinalysis to check for a UTI, another common cause of pelvic pain.
Standard workup stuff.
Pretty standard. A speculum exam to visually check the cervix is mentioned, and doing a cervical smear if one is due according to screening guidelines. So, starting with imaging and swabs mainly, what about more specialist investigations?
Correct. The notes suggest reserving those for cases where pain is severe and isn't responding to initial treatment, or if there are really concerning symptoms pointing strongly to something like significant endometriosis.
And these include?
Things like MRI scans, which can give more detailed pelvic images, and then surgical procedures, primarily laparoscopic keyhole surgery, to look inside the pelvis directly. Sometimes, rarely, a laparotomy, open surgery with biopsy, might be needed for complex cases.
But the key message from the notes is?
Diagnosis is often clinical, especially for primary dysmenorrhea, but these investigations are crucial tools to rule out or confirm underlying conditions when the picture is suggestive of secondary causes, or the pain is severe or persistent.
It really feels like these notes map out a logical assessment pathway. Start simple with history and exam, then use investigations judiciously to dig deeper if needed.
Exactly. It's about building confidence in that primary diagnosis, or picking up the clues that point towards a secondary cause needing specific treatment.
Okay, great. So once the assessment is done, we have a diagnosis, or at least a working diagnosis. Let's get to the really practical part, management. How does this material suggest we help someone get relief?
The overarching goal, stated in the notes, is clear and patient-centered. Provide enough pain relief so the person can carry on with their usual daily activities.
Making life manageable again.
Precisely. And the management approach is broken down nicely in the notes.
Let's start with the non-medication options, the general measures.
Yes, and the notes recommend these for everyone with dysmenorrhea, regardless of type. They include simple things like reassurance, education about the condition.
Understanding what's happening.
Exactly. Lifestyle changes too, like quitting smoking, given it's a risk factor. Encouraging regular exercise is highlighted. The notes specifically mention it may significantly reduce pain intensity.
Exercise helps? That's good to know.
Seems so. In self-help techniques, like using a 10NS machine that's transcutaneous electrical nerve stimulation, or simply applying heat, like a hot water bottle or heat patch.
Tried and tested methods. What about alternative medicines?
The material mentions that for many complementary or alternative approaches, there's currently insufficient evidence to strongly recommend them. So the focus is on these more established general measures first.
Okay, so start with accessible lifestyle tweaks and self-care. Then what about medication, pharmacological therapies?
These are a cornerstone of management. NSAIDs, nonsteroidal anti-inflammatory drugs, are highlighted as being highly effective for the pain.
Like ibuprofen.
Yes, the notes give examples like ibuprofen, naproxen, and mefenamic acid.
Yeah.
Because they target prostaglandin production, they tackle the root cause of primary dysmenorrhea pain.
Makes sense. What else?
Hormonal contraceptives are another key option. They help manage the pain, often by suppressing ovulation or thinning the uterine lining.
So things like the combined pill, or maybe an IUD.
Exactly. The notes specifically mention combined oral contraceptives, progestogen-only contraceptives like the mini pill or implant, and intrauterine devices, particularly hormonal IUDs.
And there's a practical point made here, too.
Yes, a really useful one. If the individual also needs contraception, then hormonal methods are often considered first line because they can tackle both issues, pain relief and pregnancy prevention simultaneously. That's efficient, combining goals. Very much so. The material also notes that treatment can often be started empirically, based on symptoms, and then adjusted depending on the response. You don't always need definitive investigations before starting treatment for likely primary dysmenorrhea.
Okay, good point. Now, what about surgery? The notes mention some options, but with caveats.
Yes, surgery is generally reserved for cases that don't respond well to medication or when there's a clear secondary cause like endometriosis or fibroids that needs surgical treatment.
And one procedure is specifically not recommended.
Correct. The notes mention laparoscopic uterine nerve ablation, or LNA, and they explicitly state it is not recommended for primary dysmenorrhea because the evidence just doesn't show it's consistently effective.
Okay, so LNA is out according to this material, but what about diagnostic laparoscopy? Looking inside.
Diagnostic laparoscopy is mentioned as a valid option, particularly for persistent symptoms where you strongly suspect an underlying pelvic disease like endometriosis that hasn't shown up clearly on scans. It allows you to see directly and potentially treat what you find.
Right, find and treat. Any other procedures?
Endometrial ablation is listed. That's a procedure to remove or destroy the uterine lining. It's noted as an option specifically for patients who have both dysmenorrhea and heavy menstrual bleeding, as it can help with both problems.
Targeting both symptoms again.
Exactly. And finally, the most definitive surgical option mentioned is hysterectomy, removal of the uterus.
When is that considered?
The notes state it's considered for women who have completed their childbearing and continue to suffer from severe, persistent dysmenorrhea that hasn't been helped by any other treatments. It's described as a definitive surgical therapy in that specific, quite limited context. Yeah, the structure in the notes is really helpful for revision here. Moving logically. General measures first, then medications like NSAIDs and hormonal options, and then considering specific surgical interventions, knowing which ones are supported by evidence and which aren't, like LNA.
It's really comprehensive. From simple advice and heat packs, through different medications, and clearly outlining the role and limitations of various surgical procedures, these notes definitely lay out a full management pathway. Okay, finally, let's look at the longer-term picture. What do the notes say about prognosis and any potential complications?
The prognosis, generally speaking, is good. The notes emphasize that most individuals find significant relief and improvement in their symptoms with the right management strategies.
But does it usually go away completely, or is it something people manage?
The notes acknowledge it's often a chronic condition. Symptoms may well recur with each cycle, but the key message is that with proper ongoing management, these symptoms can be effectively alleviated. And really importantly, the person's quality of life can be significantly improved.
That's the main goal. And are there complications directly from the pain itself?
This is reassuring. The notes are quite clear. Dysmenorrhea itself doesn't typically cause direct physical complications or long-term bodily harm.
Okay, that's good to know. No lasting damage from the cramps themselves.
Right. But, and this is big, but the material strongly highlights the impact a condition can have. Severe pain, along with those associated symptoms, can really interfere with daily activities, work, school, social life, basically overall quality of life.
So the impact is the main issue.
Yes. And crucially, coming back to the secondary causes, the notes state that the underlying conditions causing secondary dysmenorrhea absolutely can lead to serious complications if they're missed, left undiagnosed, and untreated. Things like infertility with severe endometriosis or PID, for example. And that brings us full circle, doesn't it? Back to why that initial distinction between primary and secondary is just so fundamental. While the pain of primary dysmenorrhea isn't damaging in itself, severe uncontrolled pain drastically impacts life. And ignoring potential secondary causes can lead to much more serious health consequences down the line beyond just the pain.
Right. So the core message on complications is really twofold: the significant impact on life from severe pain, and the potential for serious issues if an underlying secondary cause isn't identified and managed appropriately. That really rounds out the picture painted by this material. And that wraps up our deep dive into these MSRA notes on dysmenorrhea. We've really covered the ground, the definition, that absolutely crucial primary versus secondary distinction, the why behind the pain involving prostaglandins, who's most affected, and the risk factors, what the symptoms actually feel like, the checklist of other conditions to think about, how doctors investigate, the whole spectrum of management options from heat packs to surgery, and finally, the long-term outlook.
It's a really good example, I think, of how breaking down complex information from revision notes like these makes it so much more digestible and hopefully memorable. Understanding that fundamental difference between primary and secondary dysmenorrhea truly does guide everything that follows: how you investigate, how you manage, and understanding the prognosis.
Definitely. The core goals being effective pain management and, more necessary, identifying and treating any underlying cause.
Absolutely.
So, thinking about that point the notes made about the significant impact severe uncontrolled pain can have on daily life, it really drives home why finding effective management isn't just about physical comfort, is it? It's about enabling people to actually live their lives fully. What aspect of this material stood out most to you as a key takeaway for revision?
Hmm. Good question. For me, I think it's that clarity on the management options. Knowing that tiered approach start with lifestyle, then NSAIDs are first line for pain, consider hormonal options, especially if contraception is needed, and being clear on the specific surgical indications, including knowing not to recommend LUNA. That provides a really practical framework. It feels very applicable to answering questions on the topic.
Agreed. That structured approach is really helpful. And remember, everyone, this deep dive was based on high-yield MSRA revision notes. So if you are preparing for the MSRA and looking for more resources like these, there are some great places you can check out.
That's right. You can find more resources and dedicated support over at pathomsra.com.
And also at freedsra.com.
Both excellent resources.
Well, thanks for joining us for this deep dive into dysmenorrhea. Hopefully this journey through the notes helps solidify your understanding and recall of the key points. Join us next time for another deep dive.